So, welcome back. It's my great pleasure to introduce our keynote speaker, Dr. Rebeccah Slater. Rebeccah is a professor of pediatric neuroscience and a senior Wellcome fellow in the Department of Pediatrics at the University of Oxford. Rebeccah studied physics at the Imperial College and neuroscience at UCL, where she also got her PhD degree. And so since 2013, she has led the Pediatric Neuroimaging Research Group with a focus on mechanisms that underlie the development of pain perception in the human infant. So in 2017, she was elected as a young scientist by the World Economic Forum. We are very much looking forward to your talk. Rebeccah, thanks for coming.
Well, thank you very much for the kind introduction and inviting me to speak with you today. So anyone who heard the brilliant talk by Jeff Woods yesterday doesn't need me to tell you that pain is fundamentally protective. It prevents us from damaging limbs, it educates us, and it drives others to give compassionate care. But when we think about pain in a newborn child, this isn't what we first think about. We think that these functions are provided by parents or siblings or grandparents, very much in a home environment. But that is simply not the case for the 1 in 7 children that are admitted to hospital after they're born. And this could be for diagnostic procedures or for investigations or treatments. They can receive a high number of painful procedures per day. And pain relief is really quite rarely provided for these procedures, even though we know there can be long-term consequences from these early life experiences. So I was writing a review the other day and I was happily tapping away. Predisposition to undertreat pain still exists in clinical practice. And I'd written this at least in 2012, where I'd gone to the NHS guidelines on this topic, and it had said, in small babies, being cuddled and fed is more important than painkillers. However, in 2022, they updated these guidelines and further improved them. They now say the baby's head is held securely while sharp, sterile scissors with blunt ends are used to cut the skin. In very young babies, these procedures don't seem to hurt. But by 3 months old, you should give a general anaesthetic. Now, I'm pretty confident that the reason you're giving a general anaesthetic at 3 months is because the baby is likely to bite you, rather than any fundamental shift that's happened in the first 3 months to that point of view. So I happily left my statement in my review that there is still a predisposition to undertreat pain. And it's not just one NHS guidelines, I had to triple check, and you can see this is everywhere throughout guidelines. My favourite one here is that this procedure is painless, and the reason the baby is crying is because they don't like to be swaddled or they're hungry or tired, not because we're about to cut their tongue with a pair of scissors. And this is everywhere. So clearly there is a predisposition to undertreat pain. So where did this come from? Well, I'm going to give you one example of a study that was in paediatrics in 1962. They were looking at cry thresholds of normal infants. And what they show in this study is that if you take an elastic band and stretch it, nicely put with a gun-like apparatus, then normal infants don't seem to cry as much as children who are greater than 4 months old. And it was studies like this that really led to this idea that babies didn't feel as much pain as others. Also, they were thought to have an immature nervous system, which perhaps led to an incapability of experiencing pain. The lack of memory was somehow equated to a lack of experience. And protective mechanisms that may be there during childbirth in order to prevent us feeling pain during this period may still exist in these early days. And indeed, observations that were being observed, such as reflexes and crying, may not directly be related to emotional experiences. So while we were all happily reading these papers in 1962, I think we might have been better reading some poetry by Dr. Seuss. And in an ode to keeping all the keynotes having poetry, I thought I'd share this poem with you about the Chippendale mutt who has just bitten his tail, which he does every night before shutting his eyes. Such nipping sounds silly, but really it's wise. He has no alarm clock, so this is the way he makes sure that we're awake at the right time each day. Till the nip makes the trip and gets to his brain, in exactly 8 hours, the Chippendale mutt will at last feel the bite and yell ouch and wake up. So Dr. Seuss clearly understood that pain was very sluggish, infants are very slow, and perhaps if we'd read a little more of this, rather than some of the studies that were in paediatrics at the time, we may have come to the same conclusion. Now, there really has been a seminal change in the treatment of pain in infants. And if you take things like surgery, then this is really well treated now. And indeed, driven by some of the important work that was done in the 1980s, in part led by scholars including Sunny Anand, where he justified a rational post-operative regime that should be provided for infants during analgesia. And certainly this was published in 1987, and the practice of not giving pain relief during procedures like this really did stop. And just as an example of one survey that was done at this time, this was a UK-based survey where in 1988 only 10% of anaesthetists provided systemic opioids during surgery, whereas by 1995, 91% of the respondents to this survey had changed their practice. So certainly practices have changed, but there still is very much an underappreciation and undertreatment of pain in children. So where has this come from? Well, very simply put, it's because babies can't talk. They can't tell us where the pain is, they can't tell us the intensity, and they can't tell us whether the treatments that we're giving are actually working or alleviating their pain, or whether we need to change them. So what do we do in the absence of language when we're trying to think about pain? Well, really, all you can do is observe all of the responses that you can see in a child when you do something that you know is painful. And on this slide, I've given an example of some of the things that will happen to a baby if they have a painful procedure. For example, they'll have crying, they'll show facial grimacing, their heart rate will go up, their oxygen saturation may go down. And I've highlighted in blue here 3 of the different measures that really form the majority of most clinical pain assessment tools. But there are challenges with these measures. They're not specific enough in that babies will do these to a whole range of things, whether they're hungry, they're tired, they want to cuddle, or they're in pain. And they're not very sensitive. If you do things where you consider the pain is graded, they don't really align with these responses. And I'm just going to give you one example of one study that demonstrates the limitations of using things like facial expression. So here, 100 or so babies either had a heel lance where the blood was taken from the heel when the blade went into the foot, or in the other half, the heel lance, it was rotated by 90 degrees, so the blade did not go into the foot, but the rest of the experience was the same. Well, if you take the babies from 28 weeks gestation, so these are prematurely born babies, the number of babies that will have a facial grimace response to either the heel lance or the control event where they didn't have the nociceptive input is around 50% in both cases. Now, as the younger babies mature and they start responding to the heel lance, the percentage of babies who will cry in response to a blood test is nearly around 100%. However, if you look at the babies responding to the control event where it's just the touch, this is reducing to less than about 10%. However, if you start using measures like facial expression below the age of 32 weeks, then really it can become very hard to discriminate between responses to alerting stimuli or responses to nociceptive stimuli. So what can we do? Well, one approach is to start looking in the brain, because the brain is the organ where the perception of pain occurs. So in the absence of language, if you can look at the brain, maybe it can tell us a little bit more than just looking at motor observations that might not be quite so directly related to the experience. And to do this, we can use a number of measures. We can use near-infrared spectroscopy or EEG that can be done at the cot side or while a baby's being held in the arms of their parents. Or we can do MRI, where we can take them to an MRI scanner and start looking a little bit more information about the spatial organisation of what happens when a baby is experiencing pain. And in most cases, these studies are done where a lancet is used to take a blood sample from the foot, because it's one of the easier ways to get an evoked response. Of course, this doesn't solve all the problems around spontaneous and ongoing pain, which is certainly an important aspect in the field, which we're really trying to think about now. Whoops. So back in... So looks like some of the animations aren't working here. So you're not supposed to see pictures of the Daily Mail here. You're supposed to see that back when I was doing my PhD, we were able to record a response to a heel lance stimulus. And when we did this, we were confident that we were able to see a signal. However, what you're supposed to now see is that this was reported by many people as babies experience true pain. Now, this simply wasn't the case. We didn't show that. We showed that if we did something noxious to a baby, we could record a signal in the brain. So, nevertheless, it gives us a lot of work to try and build on these early observations. So, what do we actually do? So, we develop new methods. The methods that are used to measure pain in adults and to do brain imaging in adults are simply not good enough to be able to look at neonatal brain activity, because the neonatal brain is very different. And I will tell you a little bit more about some of the differences that are important when you're starting to think about doing imaging in the neonatal population. In addition, we asked some basic neuroscience questions. So when is the human brain able to discriminate between a tactile or a noxious stimuli? How is the inflammatory responses and pain responses related in early life? And then ultimately, can we use these to improve the pain treatment in babies? Can we actually take these measures and test the efficacy of analgesics or other interventions that we use in order to try and reduce pain in this population? So, what have we learned? Well, as I said, in the 1980s, surgeries were routinely performed without sufficient analgesia, and this has very much been shown not to be the right approach. Certainly, facial expression became a very important indicator to suggest that babies were responding to painful experiences back at that time. And comparative studies between animals and infants were being done, particularly pioneered by Mariah's group, where we could start to understand some of the underlying physiology and do some translation between these different groups. The long-term consequences of early life pain were being recognised. fMRI began to be used to actually measure clear and specific responses to nociceptive input. And these were able to be used to look to see whether analgesics, in the case of the Lancet study, it was looking at morphine analgesia, to see whether it was effective for babies. Certainly, we're able to start doing some comparative studies between experiences between adults and infants, and indeed other species. And we started to understand where some of the variability in pain comes from. And certainly today I'm going to tell you a little bit about the impact of early life inflammation on pain. So how do we do these studies? So they're all done in a neonatal unit, and where a team of technicians, clinicians and other doctors are placing electrodes over the surface of the baby's head during a clinically required procedure. And this can be done both at the cot side, as you can see here, or it's also possible to take the babies out of these settings and to go into the MRI setting. You can see the traces here. So when these stimuli happen, you can actually look in real time, looking at some of the changes that are caused by the different stimuli. And here's an example where a stimulus is applied, and even the parents can see it. In fact, one of the most heartwarming things I have ever done when I was a student is a parent saw us touching a baby next to their baby, and each time we touched the baby's foot, they could see this pattern of activity in the baby's brain. And the parent said, "Can you do that to my baby? If I touch my baby, will they be able to see it in the brain?" And it was just that disconnect that these parents can sometimes have, because these children are in incubators, separated from them. Of course we said, yes, your baby knows that you're touching your baby. And indeed, she took part in our research study, and she touched the baby, and you could see these responses. So I'm going to focus on the changes in the brain activity, as we've just discussed. So here's a study that was done in MRI, and it was a comparative study between the pattern of brain activity that was evoked in an adult when they stated they were in pain and when we applied a similar stimulus to a baby. The parents described it as a bit like being poked with a pencil, so it was a very mild nociceptive stimulus. It wasn't at an intensity that evoked a behavioural response, but it was mildly nociceptive. And what you can see from this study is that the pattern of activity in the adult brain is really quite similar to the pattern of activity in the baby's brain. Now, there are some differences. There are some areas that weren't activated in the baby. For example, we didn't see amygdala activity. But in general, there were very similar comparisons. And this included areas that are more associated with the sensory aspects of pain and also the more affective and motivational areas. But that was just a picture. All you saw there is a set of blobs in adults and babies that, look similar. And we didn't make any more claims about it than that. But can we look a little bit further into this and really be confident that the measures we're taking in the babies are accurate? And it comes back to using bespoke approaches to measure activity in the children. And this is because the babies move around in a very different way to an adult in a scanner. Their hemodynamics are really sluggish, as Dr. Seuss appreciated. They're much slower, so it takes longer for these signals to get to the brain. The infant's brain is much more watery, so the tissue contrast is very different. And even over a period of just a few weeks, there's a huge variation in size that needs to be accounted for. But if you do account for these images and you don't just use adult pipelines, then you can get really quite detailed images where we're very confident that we're measuring accurate activity in these children. So by doing this, we collaborated with Tor Vega. And I'm sure many of you are familiar with his work, where he took some neurological pain signatures in adults and demonstrated that these signatures really corresponded to some changes that we would expect. For example, they encode intensity. They responded to analgesic interventions and were able to discriminate between different types of pain. Well, if you transform these signatures so they're suitable to be able to be used in the immature brain, and then start to see how the patterns of activity compare, we got a really clear comparison between the adults and two independent cohorts of infants. We weren't able to go up to the intensity that was applied to adults because that wouldn't be ethical in the infant population, but certainly at the intensities of 64 and 128 millinewtons, we saw similar encoding in the neurological pain signature. But we also applied a signature which is stimulus-independent signature. So this wasn't a pain signature that Tor had developed that encodes pain intensity, but encodes some of the other aspects of pain. And here you can see that when we applied this signature, that we didn't get the same comparison between the adults and the infants, suggesting that perhaps some of the connectivity within the brain is quite different between the adults and babies, and maybe some of the more emotional constructs that we ascribe to adults may be very different, as we might expect in a naive one-day-old child. Even in newborn babies, and this is just an example of 3 babies that we studied within the first day of life, you can see there's huge variability between these responses, as you might expect if you were to look at adults. So can we explain this variability? Can we understand why some children seem to have much more heightened responses while others seem to be more diminished? So we took 18 babies that had these different responses across the age. And the first thing we wanted to do is be really quite confident that this is physiological differences we're observing, not just differences technically. So in order to create these kind of images, they come from time course data that you can see here. And what I'm really just showing here is that the time course data between our predicted responses and expected responses were really good across all of the different babies, regardless of the magnitude of the response. So we do think that this is physiologically different. So what can we do? Well, there are a number of different imaging techniques where we can start to look at the structure and the functional architecture of the neonatal brain. For example, we can use diffusion MRI to look at the white matter microstructure. We can look at functional MRI, so to look at the resting state. So what's the brain doing when these children are just lying there at rest? And we can also look at evoked responses to known nociceptive or non-noxious stimuli. So when we do that, what we can say is the state of the brain at rest, so this is what the brain is doing while the baby is just lying there, is highly predictive of the way they will respond to the noxious procedure. And there's a really clear correlation, but actually we collaborated with the DHCP group in King's at looking at the Developing Human Brain project, and we took their very large cohort of 240 babies to create our predictive models, then applied them to this data. So Just the organisation of the brain does drive these responses. But it's not just the functional organisation, it's also the structural organisation. So if you start looking at the different white matter tracks, you can start to see that based on these properties that you can start to make predictions about these responses. So I'm just going to give you one example here of how the organisation of the brain, even in a newborn baby, might influence their responsiveness to nociceptive input. So this was a study that was done by Irene Tracy and Marcus Ploner back in 2010. And what they showed is that when the descending pain modulatory system is highly connective, so that means all the brain regions involved in that system are really kind of temporally responding together, then a highly connected descending modulatory system relates to a lower pain response. So what we wanted to know is in a newborn baby, if we have a more connected descending pain modulatory system, does that also link to a change in the magnitude of the responses? And indeed, when we looked at the same areas with the same connectivity, we were able to show that the pre-stimulus connectivity of this network is related to the magnitude of the response. So far, I've focused very much on some MRI studies, but really the mainstay of what I've been working on has been EEG, because it can be used at the cot side and it can be used as outcome measures in clinical trials. Now, I'm not going to go through a, I think, 20-year history now of different studies we've done on this, but just very briefly, we saw that there were some similarities between the adults and infants in the MRI. There were also differences. This example just shows you that the baby's responses are much less well lateralized than the infants are. We've also looked at these responses to see if they are specific to the nociceptive input. So here we applied light and sound and touch and pain to see whether we got these particular patterns of activity that you can see here. Now, we didn't see them in response to the non-noxious procedures, even though they were equally arousing. And by equally arousing in this context, I mean that they caused an increase in heart rate, which was matched to the increase in heart rate of the nociceptive input. And this is simply because if you go up and clap in front of a small baby, their heart rate will rise. If you flash a light on, their heart rate will rise. In fact, every time somebody walks into a neonatal unit, the heart rate of all of the children can fluctuate in response to these stimuli. But when you match that arousal, we still do not see this pattern of brain activity that occurs 500 milliseconds or so after the noxious input in response to any of the non-noxious stimuli that we've applied. And importantly, if we did an obvious study, like applying some local anaesthetic to the surface of the skin before applying these stimuli, the magnitude of these responses come down. They're correlated with reflexes, which is important because we can see these reflexes and we understand some of the physiology of these responses. And really importantly, they relate to clinical pain scores. So if you have bigger responses in your brain, you're quite likely to have a higher clinical pain score. However, this still highlights the important point that in about 30% of the cases, the babies didn't have any behavioural responses, yet we were still able to see these changes in brain activity. And this is going to be an important point that I come up with later when we start thinking about the consequences of sepsis, for example, where a baby is very lethargic. They don't necessarily have the energy to mount a really vigorous response, and yet they can still respond to nociceptive input. So this is perhaps one of the most important studies I'm going to share. This is some work that was done in collaboration with Lorenzo Fabrizi at UCL. And they were very generous in that they shared all of their data and made it open access and available to everyone. So what we did is we took their data that was available open access and we plotted it in babies from 29 to 39 weeks. And then we took our own data set and did the same thing and plotted it. And we hadn't collaborated for 10 years at all, so these were done completely independently. And what we could see, it was almost remarkable. It was like we'd drawn our data on top of each other throughout this 10-year period. So this really tells you something about the robustness of these signals. Now, we also measured behavioural responses for all these babies, but we were not able to get anything like as close a match in terms of our behavioural response compared to this. And in part, that's because the behavioural observations are much more subjective. This involves looking at a baby for, say, 30 seconds and working out how much movement there's been across the face. So this is really important when we start thinking about doing things such as multi-centre clinical trials to actually assess whether analgesic interventions can modulate these signals. And it gives us great confidence that there is consistency across various groups. And in doing that, we've been able to work with regulatory agencies, such as the FDA, to really try and see whether we can develop these endpoints for analgesic drug development. Because at the moment, no analgesics are licensed in babies under 3 months old. And in part, that's because the measures that are currently being used are not sensitive enough. I mean, just as a very simple example, if you take a baby and you were to say, do you give a vaccine or something, and you were to put some local anaesthetic so they couldn't feel it, and then you used behaviour as an outcome measure, you might conclude that the local anaesthetic doesn't work because the baby will still cry. But that might be because you've taken the baby from their mother, you've held them, and you've removed them from their environment. So you can see that these kind of measures can't necessarily discriminate between, say, the pain and the distress. But if we can do this, this is a very small pilot study that was very opportunistic, where we actually gave paracetamol to babies before immunisations rather than afterwards. The paracetamol is given anyway for fever as a recommendation for this particular vaccine. But if we're going to give a paracetamol after the vaccine, why not give it before? And in this study, when the neonatal unit changed their practices, we started to look at this to see whether paracetamol, for example, has the possibility of being useful during the actual vaccination. But it's not just paracetamol. They've done this with a number of different drugs and across a number of different interventions as well. We've looked at the impact of sucrose, paracetamol, you've just seen the data, with morphine too. And more recently, we've looked at the impact of brushing at a rate that optimally activates CT fibres. And indeed, we've seen some local anaesthetic. And so by using this approach, we can start to see whether these kind of interventions work. And I'm going to tell you a little bit more about the brushing study, partly because it's just about to be published as a randomised control trial, and also it's a really interesting journey going from identifying CT fibres in microneurography studies, for example, in adults, and how taking that into human studies in babies has both benefits but also huge amounts of challenges. So we know that pain in early life that pain is dependent on early life experiences. And so this is just one example where two groups of babies were compared. One had 40 days of hospitalisation, and the other one was an age-matched group that had not been hospitalised. In this case, they were preterm babies. What we can see here is when you take these two groups, the one that's had this more traumatic life experience compared to the others, and you look at their responses to touch, there's really no difference in the response here between the two groups. So this is really positive. Being in intensive care, I think that this is what the Daily Mail said, it's still nice to hug your baby. Wasn't quite the purpose of the paper, but nevertheless, we did show that responses to tactile stimulation didn't differ based on this early life experience. But we did see differences in the responses to noxious stimulation. Now, these babies have a very complex life course, so we can't say that this is because they had experienced early life pain. There was no association with that necessarily. It was just the whole complex experience of being in hospital for the first 40 days of your life could lead to some changes that were specific to your nociceptive system. So can we start to understand why these periods of hospitalisation might have this kind of impact? And I'm going to talk about one study which looks at whether early life inflammation in neonates can impact future pain sensitivity. So we know that about 13 to 20% of infants who are born have suspected infections. Yet the consequence of this early life inflammation on human nociceptive circuitry is really largely unknown. there's a lot of preclinical literature that suggests that there are some very serious consequences, and the activation of the immune system in neonatal rat pups, in this case using LPS administration, can lead to long-term increases in nociceptive sensitivity. And there are some epidemiological studies that suggest early life trauma or disease, and presumably this is associated with a high degree of inflammation, can affect a person's long-term chronic pain. So the question is, can we design a study in neonates to see whether there are associations between nociceptive sensitivity and early life inflammation? Well, I think we came up with one of the coolest study designs here, because we took parents who had a very similar clinical history, or mothers, pregnant mothers, and we compared them for all people, to parents who had risk factors for their baby being septic. Now, if you have a risk factor that your baby might be septic, then you will be treated with antibiotics on the first day of life, and in order to prevent, the potential damages of sepsis. But in most cases, these antibiotics are stopped when infection markers are measured and they presume that there's no level of inflammation. So here we had a cohort of women who had exactly the same perinatal period history and risk factors for infection. And then when the babies had their blood test to see whether the levels of CRP were different, suggesting that there was a level of inflammation, we measured the responses to pain. And then we split the babies up for those that had their antibiotics that would go on to continue because they had a raised CRP above 10 milligrams per litre, compared to the ones that had a cutoff below this. And we use this cutoff because this is the clinical cutoff that's used to decide whether the antibiotic treatment would continue. So at this point, we've got relatively similar histories, but two groups of babies, either who have raised inflammatory markers or not. And then we compared them. So there were 61, I think, babies in this study altogether, and the majority had low inflammatory markers, and the antibiotics were stopped. But in some cases, the antibiotics were continued. And so we wanted to test a series of hypotheses. For example, is this inflammation associated with hyperalgesia? Does it lead to an increase in spinal cord excitability? And can you see increased arousal to tactile stimulation? And what we did is we grouped the two babies according to the cutoff that I just described, and what you can see is in response to noxious stimulation, there's an increase in their reflexes, but there's also an increase in their brain activity. Now, this is really not surprising. If I was feeling sick and inflamed and you come and did something painful to me, I'd reflex more and I wouldn't like it. And indeed, when we did the same study looking at tactile stimulation, we saw the same thing. In a similar way, if you've got sickness syndrome, or you're just lying in bed and someone comes and pokes you, you're probably going to respond more. So both at the time of the raised inflammatory markers, we could see these increase in responses to both the nociceptive and tactile input. Now, that was interesting, but the real question is, what happens when those inflammatory markers go back down? What happens after the antibiotics have worked? Do these babies still have raised responses to nociceptive input, or once the infection is cleared, do they go on and have a similar trajectory to the babies who did not have the raised set levels of CRP? And so we did an exploratory pilot study on this, and we did exactly what I said. We waited until the infection had gone, and then we compared it to babies who had not had an infection. And we can see that there's still a suggestion of an increased response here. Now, there's no data or no statistics here because this was just an exploratory investigation. But it gives us the ability now to really do a study where we can take children who've had early life inflammation and then follow them up at different times throughout their life to see whether they continue to have these raised responses to injections. And for example, the current normal immunisation programme for a young child will be about 20 or so different immunisations. So we can measure the responses to these, and we can see whether these early days can impact the subsequent responses to injections and other procedures. And so this is just an example of the hypothesis and the study that we want to do on this, where you can take the babies who are inflamed, we can look at whether they were inflammation positive or not, and then 8 weeks later, when they have their first injection, do we hypothesize that this will still be raised? How long does it continue for? And certainly it'll be an exciting cohort to continue to follow. So now I'm going to come on to the final story, which I'm going to share with you today, which is around the impact of parental touch on babies. So this is the results of a randomised clinical trial looking at whether applying tactile stimulation before a painful procedure to a baby can reduce their signs of physiological instability, but also pain. So why would we do this? And also, why am I telling you this story? This is really a story about clinical translation and some of the challenges that can happen along the way. So we know there's plenty of evidence that massaging babies, cuddling babies, swaddling babies is supposed to reduce pain during these procedures. And it's recognised methods that are reported in Cochrane reviews following lots of meta-analyses. And the reason is that there's lots of studies that show if you do leg massage prior to a heel lance, you can reduce these pain responses. If you do swaddling and cuddling and all these things, you can also see reductions in facial expressions and in heart rates. So we think there's some evidence that skin-to-skin contact works, for example. But that's really not very helpful if you want to write a guideline or you want to recommend it. You can't just say swaddle babies. How long for? When? How? All day? Forever? Before the procedure or after the procedure? And what it means is that these interventions that may be really successful, that are happily recommended in World Health Guidelines, we should all be doing kangaroo care, I think seemingly forever, are not used as much as something like sucrose, where it's able to say you can give this number of millilitres 2 minutes before the procedure in this way. So can we actually understand the mechanisms that are driving these positive interactions and actually try and refine it so that we can give much clearer and specific guidelines about what should be done and when and how? And in part, this is paralleled with some studies in adults where we know if you apply CT optimal stroking at around 3 centimetres per second, then this reduces the pain reports in adults. If you do it very fast, people don't like it. They say it's you're not very comfortable. And if you do it very slowly, they say it's like ants walking on your skin. So the normal rate that you would stroke a partner or caress a cat or something is around this speed. And we also know that's related to a population of CT fibres that are preferentially activated at this speed. And there's a huge amount of work around the benefits of social touch when this stroking is done. So in a preliminary pilot study that I had to get 2 sets of students to do twice because I wasn't convinced the results were right the first time, although when the second student did it 3 years later, the results were exactly the same. We asked a researcher to take a brush and stroke the baby for 3 centimetres per second before a heel lance or for them not to stroke. And as I said, what we were able to see is there's this reduction in the noxious evoked brain activity caused when you applied this CT optimal brushing. We did it for a period of exactly 10 seconds, 1 second prior to the heel lance. In part, that was because when we were designing the study, people were worried that it might be distraction if we did it at the same time. So we applied it beforehand and we used the methodology that had been shown to be effective in the adults. But really, we don't want people to be taking researchers and stroking with brushes, in part because the calibrated brush costs £500, whereas hands are free, and they're also room temperature, which is also supposed to be beneficial for this stimulation. So we wanted to take these observations that we'd seen in the experimental setting into a clinical trial and ask parents to stroke at these rates prior to these procedures. So we did a randomised study of 112 babies. The primary outcome measure was this noxious evoked brain activity that I've been describing. And the secondary outcome measures were post-procedural tachycardia. We know if we do something painful to a baby, we raise their heart rate. So could we reduce the percentage of babies that were becoming tachycardic if they were being stroked by their parents? And we also looked at the standard clinical pain scores that are routinely used. In addition, and really importantly, we also did a lot of measures of parental anxiety and happiness to be involved in caring for their babies in this way. In part because there is still quite a lot of suggestion that parents may not want to be involved, and quite often when we do procedures, I mean certainly the ophthalmologists who do ROP screening tend to come in at 6 o'clock in the morning on a Monday to do it, primarily because the parents aren't there. So I wanted to understand whether parents, how they felt about actively being involved in the care for their babies. Well, to cut a long story short, we didn't show any differences between our primary or secondary outcome measures in the babies. Regardless whether the parents stroked them before or afterwards, the responses were exactly the same. In response to the tachycardia, around 20% of babies were tachycardic in both groups. And when we took this premature infant pain profile clinical score, there were no difference. And indeed, when we asked the parents about their anxiety levels, this didn't change between the two groups. However, what it did tell us, there's some information missing from this slide because these are all beautifully connected, is that parents really enjoyed being there as part of this study. They found it reassuring, empowering and useful. And it really drives the possibility that we can do this again. Because why did it work so well in our experimental setting, but it didn't with the parents? Well, I think there are two related problems here. One is when we asked the parents to do it, they didn't conform to the guidelines as adherently to the excellent PhD students who precisely stroked for the time periods that we were asking. But more importantly, I think we took away a lot of the naturalistic benefit by making parents look at a metronome and stroke their babies. And indeed, particularly for some of the dads, in fact, there was a little bit more of a metronomic approach to this stroking than looking at the baby. It was stroke, stroke, stroke. And what happens is the heart rate went up for the stroking, and by doing it in this way and stressing them out and getting them to do it for 10 seconds, we not only didn't optimise the naturalistic environment that the babies were in, but also many of them didn't do it in quite the way we would have expected anyway in terms of timing. So you can't even take a step from the researcher into this clinical setting without having these stumbling blocks along the way. In fact, since then, and other people have published this as well, if you just leave parents and ask them to sit with their baby, they are stroking their babies at these rates. And heart rate does rise initially, but after about 2 minutes, heart rate lowers and they have this more physiological period of stability. So when we redo this study, we'll do it where parents are naturalistically asked to stroke their babies in a normal setting. We won't give them metronomes. We won't ask them to do it for 10 seconds. And then perhaps we'll start to understand whether some of the dynamic tactile stimulation that is implicit in part of things like kangaroo care is being driven by a mechanism such as the activation of CT fibres. And this is really an important transition to do, and a study we will now do again. I call it failing successfully. I think I've now failed in 4 clinical trials that we've done, but all of them we've managed to publish properly because the studies have messages that enable us to lead on to the next steps. So I'm convinced if I keep going, we will find an intervention that is actually modulating some of the parameters that I've been describing. And certainly, I'm really confident that we can do this because when we surveyed all the parents that took part in this study, they were all doing it primarily for altruistic reasons. They wanted to benefit babies in the future, to contribute to science. They liked the fact that our team was monitoring them more and providing them with really careful understanding about their babies during this sensitive period. And there were some concerns about pain in this group, but I'm confident that we will be able to run this study much better. So just to summarise, I've talked a little bit about inflammation and the long-term effects of pain vulnerability. There's huge intervariability between different children, and I believe that early life inflammation may be associated with increased nociceptive sensitivity, certainly during the period of inflammation, but perhaps beyond. And I think that's a really exciting study because of the huge parallels between the preclinical and the infant literature. these brain-derived measures, they're really reproducible, so we can start looking at the organ that matters in children that cannot tell us. But there are challenges moving across in any of these kind of studies, so we just need to keep persevering in order to try and achieve this goal. But I think the work that we're doing here really is trying to deliver the transformative change that we wanted to highlight when we published the Lancet Child and Adolescent Health Commission a couple of years ago now, to really highlight the point that in young children we do need to make pain matter, we need to make it visible, and we need to make it understandable. And if we can do all of that, then we can improve the pain treatment of children in early life. And I certainly wouldn't be standing here if it wasn't for the absolutely fantastic team of people that are working away collecting all of this data. It's a large team of clinicians, engineers, technicians and neuroscientists that really all work together to be able to answer some of these questions. And I'm incredibly grateful to the team for being able to do this. So thank you very much.
Thank you very much. Wonderful lecture, wonderful data. So my question, I was a little bit, so in our hospital we're dealing a lot with patients with intellectual disability, right? And they are not, so the communication is difficult. Some of them have malformations. So I think many of them are in pain and the situation is somehow similar. Are there studies or have you some recommendations how to deal with it?
So I think the transferable knowledge of this work between other patient groups where they can't communicate so easily, even in veterinary science where they're worried about pain in animals, or anaesthetised patients or comatose patients, and more recently delirium, which has become a really a hot topic. The parallels are massive. So these measures, we can record them in babies, we can record them in adults. Certainly I saw some posters where people were recording evoked potentials in preclinical models here today. And so we can use these measures. In some ways, it's been slightly easier to take the neonatal model and get the understanding from that group compared to the adults, because they don't have any expectation or anxiety. They don't know that they're in a study. So these signals are very raw. And so actually, in a very raw system, we get these and they're less muddied. So we should start looking at them across the ages. I think maybe the kind of vaccine studies would be really good here, because then we can start to see how some of the experiences or challenges in groups like that can modulate these patterns.
Yeah. There are many questions.
So thank you. Rebeccah, my question is the difference between sleeping and waking babies. Can you apply some of these tests? I assume the babies are sleeping most of their life. And do all these stimuli, number one, always wake them up? And if they don't, are the measures you get rather different?
Yeah. So they are different. So the responses are smaller when the babies are asleep. And they're bigger when they're awake. In the MRI studies, all the babies are quietly asleep. They're certainly not moving around. So we've only looked at it in sleep there. But in the studies with EEG, we can correct for the sleep state. And you can use the EEG to actually measure the sleep state at the same time. But there is the data does suggest that the responses are lower in sleep.
So babies should only be inoculated when they're sleeping?
Well, there's a lot of questions about this around kind of comfort care, whether you should cluster the care and do things intensively, or whether you should space them out and do them in periods of quiescence. Of course, there are arguments both ways here. Sleep is very beneficial to the babies, so there are quite a lot of guidelines around how to optimise the timing of these interventions when it's possible.
Hi, thank you. Sorry. Hi, thank you. Really nice talk. When you showed the slide with the reduced activity with paracetamol and the brush, you had morphine, and there wasn't a decrease and maybe an increase. Do you have any idea why?
Yeah, so that was a study we published last year in The Lancet. The study was stopped after we studied the first 30 babies because of potential harm of the morphine. So we were using a clinical dose of morphine that is used on our neonatal unit for retinopathy of prematurity treatment. But in the babies we studied, they weren't ventilated, and so we were much more likely to see the effects in terms of the respiratory depression. And the babies who received the morphine, which too many of them needed to have increased breathing support, so the study was stopped. However, for all of the measures that we actually recorded in the very underpowered study, be it the brain responses, the behaviour or the reflexes, they were greater in the morphine group. I can't say very much more about it because of course it was underpowered, but we certainly wouldn't be doing that study again.
Rebeccah, fantastic lecture, and I loved what you said about failing successfully. That's wonderful, really. So I have a follow-up question to the previous one, because you saw that you had an effect with brushing, and not with morphine, and also not with giving sucrose, but you had it with the paracetamol. So I wondered if that tells us something about the circuitry or the maturity of the circuitry, in the sense that, I mean, is brushing working because of gait control at the spinal level, right? I mean, with A-beta fibers inhibiting activity of the C versus reward circuitry not yet quite there in the brain?
So I don't know. I do know that it doesn't matter where you apply the tactile stimulation. So it's not that it has to be in the same dermatome or anything like that. If you're stroking the back, we still see these reductions. So that can tell us a little bit more about potential mechanisms. I think, so we didn't see any changes with the sucrose in terms of the brain activity, but people do, and many hundreds of studies, see changes in behaviour. So I think there's a dissociation between the behavioural responses, the reflexes, and the brain activity, and they're differentially modulated by these different interventions. So the sucrose can be very good to calm the baby down or to provide physiology. I'm sure I'd feel very nice if you kicked me and gave me a bar of chocolate. It'd be slightly nicer than just kicking me. So, but whether it was actually acting as an analgesic in the context that it's sometimes described, I'm not sure. So there's lots of unknowns there. But as more studies are done like this, I think we can start piecing together why some of these things may be more or less effective.
Rebeccah, thank you very much indeed. What the little lancets they use, is that the equivalent to doing the same lancet on my finger, or is it a much bigger injury input, is the first question. The second question is, do they make absolutely sure that lancets are made with the sharpest blades possible, because the sharper it is, the less it hurts, and I wonder if that's changed over the years.
So it's a 2.5 millimetre blade. So on you, it wouldn't necessarily hurt. It's designed to cut the skin rather than pierce the skin. So it actually goes through a rotatory arm to cut the capillary bed. The challenge is that some of these babies are having lots and lots and lots of these done every single day. So you can look at the foot and you can see all the sites of inflammation. There are different brands. I think some are better than others. In part, I think some are better than others because some have better springs. And when we put our accelerometer onto the surface of the lancet, we get a much clearer signal. But that's not directly answering the sharpness of the blade issue. But there have been some comparative studies between the different blades, and some are thought to be better than others. But they are quite often driven by the manufacturers, so I can't be sure.
Hi, thank you for the super enjoyable talk. So I have a couple of questions here. So when it comes to, I'm not talking about clinical trials, I'm talking about clinical practice. So given the fact that you see responses in the heart rate and reflexes, as well as you see in the brain, do you think it's better to overestimate the pain and rely on those subjective measures rather than looking at the brain? Especially because those babies don't have expectations. As you mentioned, there is no the amygdala doesn't light up like it does in adults. That's my first question. The second one is, so in the babies that had high CRP levels, and then they were treated and they were more sensitive to pain compared to the ones that were normal, Do you think this is just because now they have expectations and previous experiences? And do you think if we kept the other group and wait for them until they get their first illness, they would all be together? And is that a real indication of long-term consequences, or it's just because they had it earlier than the other group?
So you can match the amount of painful experiences across the group. So for some babies, they will be having regular blood tests to test, say, their CRP, but others might have jaundice, for example, and they'd also have regular blood tests, but they might not have inflammation. So this study did not control for all of those things because it was a pilot investigation for setting up a proper study, but that is absolutely something you'd need to control for, because we know, especially from the work of Ruth Greenough in Canada, that the more tissue breaking procedures you have, the higher you have for these responses. So we definitely need to control for that. In the inflamed state here, they both had exactly the same because it was the first heel lance they both had, so it wasn't controlled for. In response to your first question, which I answered last because it's harder, is a more philosophical question. What do we do in the absence of knowledge? My opinion is we can never know whether somebody non-verbal is in pain. All we can do is observe as many different parameters as possible to look at how they're responding to known nociceptive stimuli. And we know that when you do these things, that they are responding. We don't know whether they're in pain, but we do know that we don't want them to be tachycardic or have apneas or to be bradycardic. So even if we don't know whether they're in pain, we've got some absolutely beautiful data from sort of 48 hours of physiological recordings showing that doing something like a lumbar puncture makes you physiologically unstable for up to 6 to 8 hours afterwards. So regardless of whether we think they're in pain or not, one of the things we do want to do is try and control their physiology. And I think clinically, that's very much something that people aspire to. And it's a roundabout answer of saying we don't know what that concept of pain is in these children.
Thank you.
Question in the back.
Brilliant talk. And I just want to take that last point a little bit further. Pain isn't a single thing. It's a very complex experience. And I think that's reflected in all the different outcome measures that we've got. You could look at them all as being a window into pain. But pain itself is very complex. And with adults, we're often looking at, well, what's the bit that really bothers the patient, which presumably you can't do in your children. So your EEG, you point out, doesn't always coincide with the other outcome measures of pain that you've got. For a drug trial, it'd be lovely, it has the same effect on all the outcome measures, but how do you place what you're seeing with EEG in terms of what's actually important? There's a risk that it's an epiphenomenon, isn't it? And that the thing that's really important to the baby is something else.
It's really interesting. In EEG is very often used for seizure detection. And in babies, seizures are often subclinical. You can't see them. But if you see this pattern of seizure activity in an EEG, you will treat them with anti-epileptic drugs because of the EEG without the behaviour. Now, people are very uncomfortable with that as an analogy to what you've just said. Why would you be treating something in the brain if you can't see it? But then if you think about the sepsis example that I gave, if you're lethargic and you're tired and you can't mount a physiological response, because it takes a lot of energy to cry for 10 minutes to alert your caregivers that you need attention. If you're septic, you're more lethargic and you don't do that, yet your response in your brain to that nociceptive input is higher. So what I think we need to do is take all of these measures together, use everything we can to get the best picture of this holistic response that a baby has to pain, and accept that the different measures are measuring different things. And reducing the EEG isn't enough. With the local anaesthetic example I gave, if the baby's still entirely distressed and crying, then you need to manage that too. And that might be through maternal care or sucrose or other comforting factors. But conflating the distress and the pain or trying to say one measure is better than the other, I think is a really a big challenge for the field because it's very often written.
Are there more questions? Rohini and one in the back there.
So the MRI data are really fascinating, and you already commented that you don't see much activation of the amygdala. I just wondered, in case of the poor babies that have had multiple interventions, whether there's some sort of a fear learning. I mean, do you see activation of the hippocampus, the prefrontal cortex?
Really interesting. So it wasn't just the amygdala, it was the amygdala and the orbitofrontal cortex, which we didn't see activation. As I said, that first picture was a bit of a picture. So it was showing similarities and differences, but it was we didn't use anything quantitative. I think by taking signatures like Torr-Vega's, which can separate various aspects of pains for like vicarious pain. Babies don't have any pain response if they see pain in others, for example. Now, we would expect that, but it's really nice to see that this is real if you show a baby an aversive picture, they don't have these unpleasantness responses. So I think by using those signatures, we can really start to ask those questions. We haven't done it yet. Part it's really hard to get babies to come back, and we have a problem between around a couple of weeks old when you can do these MRIs because the babies lie there and they're asleep all the time, to them waking up and living until they're about 5, and you can ask them to play sleeping lions. So there's a complete lack of information in that period. But I do think some of the MEG studies that we've done now, where we have optimised them for babies and toddlers, and indeed my own 5-year-old, where you can actually be moving around with a cycle helmet on and in a space, then you can start to ask some of these questions. So I think we need a bit of a technological development to really get into that.
Thanks for your talk. I'm thinking about the risk factors for chronic pain getting older and your inflammatory challenge. So your preliminary data suggests that you sort of have a difference in your pain responsiveness moving forward if you've had your inflammatory challenge or not. Do you think it's enough? Do you think it is enough to be considered an early life challenge, or do you think you might follow those kids through longer and look at risk factors right into adulthood?
Yeah, we definitely need to do this again, and looking at more detail. I mean, this was a very simplistic design. It's quite nice because of the comparison between the two groups, but if we really wanted to start following these children up longer, then of course these other risk factors are really important, like the exposure to pain that we talked about before. It's a long study to do. So, but it's definitely on the cards.
Because I guess I wonder if it's a bad thing to be able to recognise pain early or not. I guess. That's all.
Yeah, I mean, we don't know, not necessarily. I mean, I started off by coming to what Jeff Wood said. Pain's really important. It attracts attention. It enables you to grow to your limits. So it's needed to educate us. But this is particularly for the premature children. They should not be exposed to pain in utero. There is no reason why a baby born prematurely will have any pain, whereas they will be exposed to sound and touch and light. And in fact, I didn't really talk about the development today, but it's not until around 34 weeks gestation where you can start actually discriminating between the brain responses to touch and pain. When I thought that first, I thought that's terribly late, but why would a baby in utero need to discriminate between these things? Because it's not an experience that they would have. So I'm sure there's huge value in really looking at that question in more detail.
Okay. So thank you very much again, Rebeccah.